Our first talk will be from the lab of Dr. Louis Schwartz at the University of Illinois. And that talk will be on the intravascular treatment of long segments of experimental peripheral arteries with multiple serial balloon expandable resorbable scaffolds. And the first author on this is Dr. Rim El-Khoury, who unfortunately wasn't able to present today. Dr. Schwartz?
Well, thank you all very much for this kind invitation from the Journal of Vascular Surgery, Vascular Science to present some of our preclinical work. A few apologies. Number one, which you would see in the video, that I have gotten older, although I don't look quite as old as Dr. Dardick, so I'm not quite as scary. But number two is that I'm definitely not Rim El-Khoury. Rim is the vascular fellow at the UCSF that I work closely with. But my name is Lou Schwartz, and I'm the senior author, and Rim asked me to step in since she's doing a mesenteric bypass. Unlike Rim, I do have several disclosures, the most important of which is that I'm the founder and chief medical officer of this company, which is called Ephemeral Medical. As we all know, peripheral arterial disease is the scourge of our time. The incidence is increasing, the severity is increasing, and we are left here with only few solutions. I note the best CLI data, which are welcome, but if you notice, both arms did rather poorly. I think we can do better. And the way we do better is with better devices. There are many on the market, many more coming. The best device really for human arteries at the present time is a balloon expandable stent. A balloon expandable stent is one in which is a rigid device resides inside the artery without moving, and the artery can heal around it. And if you get the artery to heal around a balloon expandable device, then one can expect long-term patency. The self-expanding stents were quite a welcome development for their time, but they interact with the artery too completely. They bend and twist and scrape, and so the patency continues to degrade. And that was one of the primary design inputs of this device, that balloon expandable stents were preferable for human arteries. But one cannot place a long balloon expandable stent into the femoral popliteal segment for obvious reasons. Balloon expandable stents are rigid devices, so they really only work in arteries that either don't bend or bend minimally. And such is not the case in the femoral popliteal segment, which bends profoundly. So it's a problematic set of design criteria to try to both implant a balloon expandable stent into this artery and still allow it to bend and deform. This is an article from a long time ago from Julio Palma's. One disadvantage inherent in this graft configuration is the lack of longitudinal flexibility, which limits its use in straight arterial segments, or in the case of curved arteries, requires the use of short graft lengths. So one can implant short graft lengths, multiple short grafts, short stents into a long artery that bends. The artery will bend in the intervening segments, sort of like a train rounding a tight curve. The objectives of this preclinical study was to design a bioresorbable polylactide-based scaffold with sufficient radial force to withstand lower extremity movement, and to assess arterial deformation after long segment treatment using serial scaffolds. A similar purpose was to test the scaffold integrity after exaggerated mechanical stress in an animal model. And our overall hypothesis was that long segments of mobile arteries can be effectively treated with multiple short balloon expandable resorbable scaffolds. This is this very simplistic device in this experiment. More longer, complicated devices were used in subsequent experiments. This is a polylactide-based scaffold. You can see in this experiment, 2 short scaffolds have been mounted on a single balloon. The scaffolds are closed cell, which means that in a closed cell configuration, when the balloon is expanded, the scaffold will shorten. And this, in fact, is a design that's exploited in this experiment, because the shortening of the scaffolds creates this space, and the space is desired for movement of the artery. The other important feature of a closed cell scaffold or stent is that they're very strong. As you all know, one of the challenges in creating an effective resorbable scaffold for the human arteries is that they're made of plastic essentially, and it's very difficult to create something that's plastic that is strong as metal. Well, it turns out if you change the design some, you thicken the struts, and you make the scaffold pattern closed, then the radial strength can be made equivalent to metal. The model that was used is the porcine iliofemoral model, and it's used because of its extreme bending. Here you can see an angiogram of the pig with the hind limb extended, and here you can see with passive flexion with the animal anesthetized, the artery bends profoundly. The artery bends in its iliac segment, which is here. I don't know, can you see my pointer? Probably. But the the artery bends minimally in the iliac segment, which is the most popular segment for preclinical work. But in the iliofemoral segment, the femoral segment, there is profound bending. And if you measure the amount of bending and axial compression in the femoral artery of the pig, it is more numerically than in the popliteal artery of the human. In this experiment, manual flexion of the swine hind limb was afforded after scaffold implantation, and the amount of axial shortening and bending was measured using planimetric methods. Scaffold apposition to the arterial wall was assessed in vivo using optical coherence tomography, which many of you may be familiar is a light-based intravascular imaging modality. And then explantation of the stented arteries after animal sacrifice was performed. This device is created with only 2 scaffolds. So in order to fully scaffold the artery, multiple device implantations were made in the same artery. All in all, in 2 arteries, 2 scaffolds were placed. In 2 arteries, 4 scaffolds were placed. In 3 arteries, 6 scaffolds were placed. And in 1 artery, 8 scaffolds. And this way, a fully scaffolded, if you will, artery could be assessed. The total arterial scaffolded length ranged from 3 to 10 centimeters. And here's an example. On the left is a porcine iliofemoral artery treated with 4 scaffolds. The scaffolds are made of PLA, so you can't see them. Here, the artery is bent with a manual flexion of the hind limb. And you can see that even though these are balloon expandable and rigid, they are short enough so that the bending is unimpeded. And this was the point of the experiment. Here's an artery in which 8 scaffolds were implanted. So there are scaffolds implanted all up and down this artery for a length of about 10 centimeters. And here with passive flexion of the hind limb, you can see that you can sort of imagine where the scaffolds are, but you can see that the artery can bend unimpeded. And this is the hypothesis of the experiment, that one can implant an artery that bends profoundly with multiple short scaffolds and not impede its ability to bend, and not to pinch the artery to compromise, such as the lumen would be compromised. And here are some numeric data to this effect. In the non-scaffolded pre-procedure controlled target arteries, you can see that the arteries were bent only 15 degrees in extension, but then a full 110 degrees in flexion, and that flexion did not compromise the lumen. In fact, with flexion of the artery and axial compression, the artery actually got slightly nominally higher from 4.7 millimeters to 5 millimeters. Then in this panel were the arteries that are scaffolded, and you can tell that the amount of bending was approximately the same, 14 degrees to 113 degrees during flexion, and that again the arterial diameter was not affected by bending an artery housing multiple balloon expandable scaffolds from 4.8 to 4.7 millimeters. Now, this analysis attempted to discern in the arteries that compressed, what was being compressed, the spaces between the scaffolds or the scaffolds themselves, since the scaffolds are essentially stents that are a closed cell pattern. They can be compressed by compression forces. They can be shortened. Here is a graph that shows the length of the interscaffold spaces, the spaces between the scaffolds, and you can see that they generally decreased. So the artery, when bent, would compress the interscaffold space. This was expected. What was perhaps unexpected is that the scaffolds actually compressed slightly as well. So compression of the artery by bending the hind limb caused shortening of the scaffolds, as well as compression of the scaffolds themselves. This is how devices in the femoral popliteal artery of the human, this is how they withstand walking and sitting. The device compresses axially, and the non-treated artery compresses axially. Here's an OCT image. This is in life. This is an acute experiment, so the animals were not survived, but you can see in cross-section the scaffolds. OCT happens to be a modality that is particularly useful for imaging resorbable stents. So these are the scaffold struts you can see on OCT. And then here is a micro CT image. The way this is a destructive test. The way this is done is the animal is sacrificed, and the artery, the scaffolded artery, is excised and placed on the stage of a micro CT. And you can see how the scaffolds reside within the artery. This is not in life, though, so you do see some, once you excise the scaffolded artery, it does compress some, and there's no longer arterial pressure, but nonetheless, you can see how the scaffolds reside in the artery. As you may know, the development of resorbable scaffolds for human arteries has been plagued by fracture, and that was a specific design element of this device, which resists fracture because of its closed cell design, because it doesn't have to be flexible, and because of its relatively thick struts. Here's an artery treated with 4 scaffolds. This again is after the animal is sacrificed. And here's an artery treated with 8 scaffolds. In conclusion, from this experiment, we can say that long mobile peripheral arteries can be successfully treated with multiple short balloon expandable bioresorbable scaffolds. Supraphysiologic hind limb deformation did not generate significant axial compression of the acutely scaffolded artery. Arterial deformation was effectively borne not only by the interscaffold spaces, but also by the scaffolds themselves. Subsequent experimental and clinical studies will focus on the chronic vascular response to this interventional strategy. And I will say that since this experiment, there have been several subsequent experimental and clinical studies. We have a long-term study now in pigs, which follows the kinetics of dissolution and the vascular response. And we've initiated a clinical trial in Auckland, New Zealand, using sirolimus-coated, these are called ephemeral devices, sirolimus-coated ephemeral devices. And we have some early results which were recently presented at Circe. So this is an ongoing project, and Dr. Dahlman's remarks about translation are exactly relevant, because this is a preclinical experiment that we're now translating into the clinic. These are our colleagues, both at Ephemeral Medical and at Charles River Laboratories, which performed this preclinical experiment. Once again, I'd like to thank the Journal of Vascular Surgery, of Vascular Science, for the privilege of the floor. Thank you.
Well, that was fantastic. Thank you very much, Dr. Schwartz. And it has generated a substantial amount of discussion in our chat, which is good to see. I don't want to give too much time to some of these questions, so I will ask that we'll kind of touch on a couple of them here, but others can, if you could respond to some of them, that would be great. So Dr. Dahlman mentioned that this is a great area for innovation and immense clinical need. He has a colleague that has done quite a bunch of work on modeling SFA and popliteal shortening and twisting, and you all should consider planning translational and coordinate with him. I don't think that's really a question so much. And then Dr. Roy asked, do you anticipate requiring vessel prep prior to implantation?
Yes. So in fact, the clinical protocol at the present time calls for balloon angioplasty first. It's similar to placing any balloon expandable stent. I'm sure many of you do direct stenting, but the problem in the periphery is always you're afraid of losing the stent if there isn't enough room in the artery to advance the device. So yes, we have been doing balloon angioplasty. So vessel preparation will be important. Alan asks, can these resorbable scaffolds serve as a reservoir for drug release? That's been a very tough design element, Alan, because the scaffolds are made with heat, and the heat tends to denature paclitaxel or sirolimus. So that's been a tough design element. So at the present time, we are spraying scaffolds the way that drug-eluting scents are sprayed. And then Ron says, talks about Chris Chang's work, which is really a lot of this is borrowed from that great work. In fact, placing multiple short stents in an artery is not a new idea, but the question has always been, well, how long should be the stents? How long should be the spaces, et cetera, et cetera. And in fact, you can take some of these data generated by Chris and by some of our own studies and actually quantify the degree of bending and axial compression in both the superficial femoral artery and the popliteal artery. And using those data can actually create an equation. And we've done so. It's actually part of our intellectual property that you create an equation by which the length of the scaffolds and the length of the spaces can be designed such that when the leg is maximally flexed, the scaffolds don't abut. So that's a good and insightful question, Ron. And we use those studies, actually follow very closely that work. It's been very useful in our development.
All right. Well, thank you very much. I mean, I think we could talk about this quite a bit, but we don't have the time to complete this here. I do hope that you'll reach out to some of the other folks with questions and touch base with them directly. All right.
Thanks, John.
Wonderful job.